So good afternoon to all of us, and welcome to this week's meeting on our maternity service agenda. This week we are looking at shoulder dystocia. Dr. Frida Kabo, the resident at the Obstetrics and Gynecology Unit, will be leading us with this week's presentation. As usual, our legendary consultant is Dr. Hawa, who would provide some insights at the end and be happy to answer your questions as well. My name is Dominic Akateba. I'm a physician specialist and I work with Ghana Medical Help as the co-founder and director. So let's stick and stay. If you have any questions, comments, edits, kindly put them in the chat box, because you realize that after Dr. Frida starts, you'll be unable to unmute yourself so that we don't get any distractions. However, at the end of her presentation, we'll then allow you to electronically raise up your hand, and then we can ask you to go ahead with your comments, questions, suggestions to help this conversation make it richer. I must announce that in the coming weeks, we are doing practical emergency obstetric and newborn care, both in the Upper West and Upper East regions. So letters have been sent out from the regional directories for participants to be selected as POTs. I'm sure you see that on our social media handles as well. We are hoping that subsequently we'll be able to use these trainers to go into the sub-district levels and elsewhere. So we thank you for joining us for today. I'm sure, like you always learn from an hour's presentation, this would also be same way. We are happy to take your questions. Dr. Frida, Dr. Hawa, please, you can go ahead with the presentation. And thank you so much for leading us with this. Bye-bye. Dr. Hawa.
Thank you very much. And we are happy once again to be your way this lovely Friday afternoon. We're going to spend some time to talk about shoulder dystocia. And shoulder dystocia is a very interesting phenomenon that occurs in labor. It is so drastic, and we all need to know how to handle it when we are in that situation. Dr. Kabo is going to take us through what shoulder dystocia is, how we would identify it, and what we can do to relieve the woman of this difficult situation and also have a healthy baby at the end of it. Let's stay tuned. It promises to be interesting.
Okay, good day everyone. I'm Frida Kabo, Junior Resident in Obstetrics and Gynecology. And then I'm here to make a presentation on shoulder dystocia with Dr. Hawa, consultant. And so by the end of this presentation, we should be able to identify some risk factors associated with shoulder dystocia. We should be able to define and explain what shoulder dystocia is. We should diagnose and manage shoulder dystocia and also understand some of the complications associated with shoulder dystocia. Okay, so by way of introduction, shoulder dystocia is a emergency, obstetric emergency, and it is because it's usually associated with high perinatal morbidity and mortality, as well as maternal mortality. So in 2007, there was a study done by McKenzie and Associates. They reviewed about 514 cases of shoulder dystocia. Then they noticed that the babies, 70% of these babies that they reviewed had evidence of acidosis at the baby. And then 1.5% of them required cardiac resuscitation. Others developed hypoxic ischemic encephalopathy. Okay, so this is how detrimental this condition can be to their parents and also to the mothers too. They also tend to have a lot of perineal tears and vaginal lacerations, and it's a whole big issue. Clinicians are unable to predict its occurrence. However, once we are able to detect shoulder dystocia, then we'll be able to manage it appropriately. There's a need for us to prepare for the possibility of shoulder dystocia with the delivery wards at all times, and we should have a prepared plan for it because of how its occurrence can be. It cannot be predicted, so at every time we should be ready. So yes, what is shoulder dystocia? We haven't the consensus regarding a specific definition of shoulder dystocia is actually lacking. But then there have been some definitions that have come up. American College of Obstetricians, they diagnose it by saying that if you require maneuvers to be able to deliver the shoulder of the baby, then you will have a shoulder dystocia. Okay. Shoulder dystocia occurs during vaginal delivery, where the baby's shoulders are stuck behind the mother's pelvic bone after the head is delivered.
Sorry to interrupt, Dr. Frida. If you could kindly speak closer to the microphone. I don't know if you are using an earpiece. It's
Okay.
making it difficult to hear. So a lot of people in the chat box are trying to stop. Yeah, I think now it's better. Yeah.
Okay.
It's better. Yeah.
Yes,
right.
I'm very sorry. I should have. Yes, my voice, I have a sore throat, so my voice is a bit sore. I'm very sorry for that.
Yeah, sorry about it. It's clear now. Thank you. It's clear.
Okay. So as I was saying, shoulder dystocia is defined as the occurrence of, it occurs during vaginal delivery where the baby's shoulders get stuck behind the mother's pelvic bone after the head is delivered. Or you can define it as any form of vaginal birth that requires additional obstetric maneuvers beyond the gentle traction of delivering the fetal shoulders after the head has come out. Or you can define it as when the head to body delivery time is greater than 60 seconds. Now this, with the prevalence of shoulder dystocia, it occurs in about 0.2 to 3% of birth. And this wide variation is due to the differences in the prevalence of macrosomia and then also diabetes among study groups, and to the subjective nature of the diagnosis, which is actually based on the clinician or the provider's assessment of the difficulty in the delivery. So it's dependent on how much we document the shoulder dystocia, and also because we have a lot of women now who are obese due to the kind of lifestyle that they live. Okay, and so incidence appears to increase as the birth weight increases. How does it occur? So, okay, so we have here an image that goes through to tell us how the baby is delivered. I believe we are all familiar with that. So usually after the baby's head comes out of the vagina, you should have the fetal shoulders, the diameter of the fetal shoulders, which we call the sacromial diameter. It should enter it usually would enter the mother's pelvic inlet transversely, okay, because that is the widest diameter. Okay, now when the shoulder eventually gets in, it would rotate to an anterior posterior position. Since that one is also the widest diameter of the outlet, so it will remain in that position, and then it will descend at an oblique angle with the posterior shoulder ahead of the anterior one, which will allow the anterior shoulder to be able to slip under the symphysis pubis. Okay, so if this, if this diameter enters the inlet in the anterior posterior position, or the shoulder descends simultaneously rather than in an oblique angle with the posterior shoulder leading, and then the anterior shoulder can become impacted behind the symphysis pubis, or the descent of the posterior shoulder will be obstructed by the sacral promontory. Yes, so this the anterior obstruction is usually the commonest compared to the posterior. So these are just the forms. We can have the obstruction in two ways.
we have the bilateral shoulder dystocia, where both the anterior and posterior shoulders are stuck. So you can see from the image here how the anterior shoulder is stuck behind the symphysis pubis and the posterior is behind the sacral promontory. Then for the unilateral shoulder dystocia, for that one, you can see that the posterior shoulder enters the pelvic cavity, while the anterior shoulder is impacted behind the symphysis pubis. What are some of the risk factors? So the risk factors can be divided into antepartum and intrapartum. For the antepartum risk, if there's fetal macrosomia, if mother has diabetes or has a previous history of shoulder dystocia, if the mother is obese, if mother has gone through an induction of labor, or the pregnancy is posting, or mother is short-staged. For the intrapartum risk, if there's a prolonged first stage, or there's a secondary arrest or prolonged second stage, or there is the use of oxytocin for augmentation, or you have to do an assisted delivery. All of this puts the woman at risk of having a shoulder dystocia. So we diagnose it subjectively. It's a subjective clinical diagnosis, because you would have to see and be able to tell from what you see that, no, this is a shoulder dystocia and I need to call in for help. Okay, so you must suspect it when you see these things. If the fetal head retracts into the perineum after expulsion due to grave extraction from the impacted shoulders at the pelvic inlet. So you see the turtleneck sign. The head comes out and goes back in, retracts, comes out and goes back in after each contraction. Then if there is inadequate spontaneous restitution, or the fetal face becomes plethoric, so the baby's head comes out and you see that the face looks flushed, it looks reddened, and there's failure of descent of the shoulders, even though you have applied your gentle traction. So this is just an image to just show how the baby's head will look like. This is a turtleneck sign, so you can see clearly that the baby's head is stuck at the perineal region of the mother, and it looks a bit flat. Okay, so our management goal is to safely deliver the newborn before there's any form of brain injury, without causing any peripheral neurologic injury or maternal trauma. And so as clinicians, you need to be prepared at all vaginal birth, and you should have a stepwise plan for expeditious diagnosis and treatment. You have to be skilled and you have to be familiar with the maneuvers, because they are quite a number, and they must be effective in helping to deliver the shoulders. Okay, and you have up to 5 minutes to be able to deliver the baby before you at risk of, the baby is at risk of asphyxia. So there's this mnemonic that is generally used to be able to help us go through dealing with shoulder dystocia. Okay, so it's a helper approach. The helper with 3 R's at the end. And we have calling for help. You need to call for help. You need to call for midwives. You need to call for pediatricians, anesthetists, senior nurse staffs. Anyone around needs to come around to help, because it is an emergency. Then also for your E, so at that point, once you've called for help, you would have to tell the mother to stop pushing. Okay, the woman needs to stop pushing, because the more the woman pushes, the more the shoulder gets impacted behind the symphysis pubis. Okay. And then if there is a knockout cord around the neck of the woman, you have to remove that cord from there, and then you position your woman well. Then E is for episiotomy. You need to perform a generous episiotomy. You need to you need to give your local anesthesia before you give your episiotomy. This one will allow you to have room to be able to do the maneuvers you need to do subsequently. Then again, you need to drain the bladder if the bladder is distended as well. Then for the L, that's for the legs. You now institute your maneuvers. So we have the McRoberts maneuver. We'll come to all of that as we move on. So you institute your maneuver for the L. Then for P, you release. You apply suprapubic pressure to be able to release the sac shoulders from there. We'll come to that as we move on as well. Then the E is enter. You do the wood screw maneuver. We'll talk about it. Then the next R is for the removal of the posterior. The other R is to roll the patient over on hands and knees. And the last one is to repeat your drill once again until your time is actually up and you have to move on to other maneuvers. Yes, so as I said earlier, you need to call for help. You have just 5 minutes to be able to relieve this shoulder impaction. So you need to call for help. You are calling people around to be able to help. You need to tell the woman to stop pushing as well. I spoke about all this earlier on. And you need somebody who will be keeping time for you. There should be a working clock in the labor ward, and you need somebody to be keeping time and be announcing it as time passes by once you have made the diagnosis because of the time you have to be able to deliver the shoulders. So this is just an algorithm to help us with the drill on what you need to do once you identify a shoulder dystocia. Okay, so yes, so the first thing you need to do is to call for help. You ask the woman to stop pushing. Then you institute your maneuvers. You start with the McRoberts maneuver. Okay, now with the McRoberts maneuver, you're asking for help for people. You want two assistants to hold the two legs of the woman and then adduct it. So you are pushing it towards the abdomen of the woman. Okay, and then you are asking her to bear down again. And you try to apply your fashion to see if you'll be able to deliver the shoulders. If that fails, then you can apply your suprapubic pressure. So the suprapubic pressure is directed downward and lateral to dislodge the anterior shoulder. And you're trying to do that so that the shoulders will be dislodged away from the symphysis pubis. Whilst you have your midwife or the clinician trying to apply the downward traction to be able to deliver the baby. If that fails, then you can do your Rubens maneuver. Okay, so with the Rubens technique, it's also known as the reverse screw maneuver. For that one, you apply pressure on the posterior surface of the posterior shoulder, and you try to rotate the baby away. So they are rotating the baby forward so that the anterior shoulder will be dislodged away from the symphysis pubis. You can deliver. So you are rotating an angle of 180 degrees to be able to dislodge the anterior shoulder. Then we have the wishbone maneuver. So the wishbone maneuver is the opposite. So that one, you are applying pressure to the anterior surface of the posterior shoulder, and you are rotating it into 180 degrees direction so that you can dislodge the anterior shoulder, and then you will deliver your baby. If that fails, we have the Montecoglu maneuver. So this is one of the new maneuvers that have been introduced. Okay, so for this one, you use your middle fingers of both hands, you insert it into the axillary region of the baby, and you try to apply or you pull the shoulder downward along the curve of the sacrum so that you'll be able to grasp the hand of the baby and deliver it. So in the delivery of the hand, You can either flex the forearm at the elbow if it is extended.
Dr. Frida, very sorry to interrupt again. I think the sound is gotten worse. It keeps undulating. So if you can speak directly into the microphone, and
Okay.
I'm sure, yeah, this is better. This is excellent. All right, thank you.
Okay. All right. So as I said, with the delivery of the posterior shoulder, okay, you can either flex the forearm at the elbow if it is extended, or you deliver the arm by sweeping it across the chest and the face of the fetus. So you can see that in the image. If that fails, then you can do your gaskin, which is also known as the all-four maneuver. So you ask the patient to roll over onto the knees and then the hands. And then this one would increase the space in the hollow of the sacrum, and also it will take advantage of gravity so that the shoulder that is impacted anteriorly will be dislodged, and you can apply your gentle traction to deliver a baby. Now, if all of this procedure fails, then you can consider a clavicular fracture. Okay, so you try to press on the anterior clavicle against the ramees of the pubis symphysis until it breaks. Okay, so this one will shorten the basacromial diameter. Then you deliver your baby. Or you can do a symphysiotomy. This one is a surgical procedure whereby you are cutting the cartilage of the symphysis pubis. Okay, so this one, a lot of clinicians don't really like to practice this one because of some of the complications associated with it. Then we have the Zavanelli maneuver. Okay, so for that one, you are trying to push the head back in to the pelvis. You are pushing the head back into the pelvis so that you can go and deliver the woman via a cesarean section. Or you can, if that one is not working, you can do the abdominal rescue. You still take a patient to theater, then you do a low transverse hysterectomy, and then try and rotate the baby inside so that you can deliver the baby vaginally. Then you close up the abdomen. So after all this, so you do this drill, as I said, you have 5 minutes. Once you have gone through it and it doesn't work, you start all over again and go on and on until you are able to get your baby out. Now, documentation is very important because we need to be able to know how often that happens, and then we'll be able to use that to advise ourselves on how we need to get ourselves prepared for shoulder dystocia. And so your documentation needs to be accurate and comprehensive. You need to document the time you delivered the baby's head and the direction the head was facing, the maneuvers you did, the timing and the sequence, the people who were involved when you were doing the maneuvers, and the condition of the baby. Because sometimes this thing can be, it involves a lot of litigations. We really want to be sure that you didn't do anything to cause harm to the baby. Now, what are the complications? The maternal complications includes postpartum hemorrhage, can have a uterine rupture, perineal lacerations, diastasis, or rectal vaginal fistula. And then some of the fetal complications include the brachial plexus palsy, that is the EPS or the Klumpke's palsy, or the clavicular, you can have a clavicular fracture of the humerus, fetal hypoxia, or fetal death. So this is just an image to show how the injury can occur. So once there's an impaction over there, you have a shoulder dystocia, and you keep applying the downward traction, you keep doing it over and over again, you can cause harm to the nerves here. Okay, so then there's a brachial plexus damage over there. And this is what can result out of that. You can have an EPS palsy. So you can see how the arm is rotated outwardly. It looks like the waiter tip deformity of the wrist. And you can see the atrophy of the muscles over there. There's diminished length of the arm. And the face also looks like it's drooping. There's drooping of the eyelid. You see the pupil also getting smaller. Okay. Then for Klumsky palsy, you can see that there's severe limb atrophy there again. There's a claw-like hand over there as well. So you can just see how you can just see clearly that, I mean, once you keep doing the traction and the shoulders are still not delivered, this is what would happen. You are stretching the nerves and causing injury there. If you keep doing it, then you get the nerves ruptured, or you can eventually end up with an avulsion. So you are just pulling the whole nerve roots from there, which is even more detrimental. Okay, so with our recommendations, we recommend that the simulation trainings and drills must be conducted to help the staff to prepare for shoulder dystocia. Okay, so this one will help us to be able to recognize and be able to manage shoulder dystocia better. Okay, so I had a short video to display for us to all see. So if you can just give me a few minutes, I'll just upload it and then.
So we can take the questions while we put the video on. It's just a 3-minute video on how to do the maneuvers. So we can start with questions whilst we get the video up. Thank you very much for listening.
Great. I think this has been excellent, concise, straight to the point, and in less than 30 minutes. Like Dr. Howard mentioned, please, if you have any question, feel free to unmute yourself and ask. Whilst she pulls up the video, if you have any questions, please feel free to unmute yourself and ask. Sincere apologies for our sound issues at the beginning of the presentation.
Yeah, sorry. Yeah, Frida has a cold and her voice is just hoarse. So that's why we have this low sound. We apologize for that. It's nature. Sorry.
Yes, speedy recovery to you, Frida. So any questions, just feel free to unmute yourself and go ahead. Or if you have comments, additions, suggestions, please feel free. We have a good amount of time to spend on the discussions. Don't feel shy. Please just unmute yourself and go ahead. If you want to make use of the chat box as well, if you feel shy to ask the question, the chat box is also available. You can type in and then I'll read it out to Dr. Howard and the entire team. I see a couple of colleagues on the maternity service agenda, Dr. Caesar, Dr. Amoeba, and Stacia. Stacia all the way from the US. Stacia, how are you doing?
I'm doing great. And how are you doing? This has been an excellent presentation. I included in the chat a picture.
Yeah. Yeah, I see the picture. Do you want to describe what was being done there?
This is an example of Mick Roberts being done by the midwife in the field, kind of running obstetric drill.
Excellent, excellent. So we'll be using
the midwife who's in the picture is on call. She can introduce herself.
Yeah. Please do if you're on. So we'll be using a couple of these mannequins as well during the practical drills next week in the Upper West, and then next 2 weeks in the Upper East. Yeah, Veronica Bayo, kindly unmute yourself and go ahead. I see your hand is up. Hi, Veronica, your microphone is muted. You could unmute yourself and then ask your question. Okay, Dr. Frida, probably as we wait for Veronica, maybe you can go ahead with the video.
Yes, please. Okay, thank you. Okay, so you can clearly see a baby in the uterus, and you can see the pubic symphysis. Okay, and the anterior shoulder, in shoulder dystocia, you would see that the shoulder will get impacted. So you can see clearly from the video where the anterior shoulder has gotten stuck behind the symphysis pubis. Now, when you keep applying traction, you want to deliver the shoulders and keep applying the traction. This is what will eventually happen. So you keep stretching on the nerves, the brachial plexus, the nerves over there, you keep stretching it, and you keep causing injury to the nerves over there. Okay, so the bobbing of the head is the turtle sign. So you can see that the head comes out and goes back in. It comes out and then it goes back in. Okay, so now that you have recognized that you have to call for help, you call your nurses, the midwives, pediatricians, anyone you can get around to come and help. Okay, so now we are going to the macrobus position. So with the macrobus, as I said, you flex the hip toward the abdomen of the woman, and then you can apply your gentle traction. If that fails, then you do your suprapubic pressure. You apply it so that you can dislodge the shoulder anteriorly, and then you can deliver the baby. Then you can do your corkscrew maneuver. Okay, so you can see that the fingers are applied on the anterior surface of the posterior shoulder to rotate the baby in 180 degrees so that it will dislodge the anterior shoulder here. Or if that fails, then you can do the Robins 2 maneuver. Okay, so with the Robins, you have the two fingers at the posterior surface of the anterior shoulder. You rotate it in one. And then you deliver your baby via a gentle traction after you've done that. If that fails, then you have to reach out for the elbow of the baby. So you try to deliver the posterior arm. So you slip your hand in from behind, you grab onto the elbow of the baby, then you deliver the posterior arm. Yes, so these are the basic maneuvers we have. If all of that fails, you repeat, you try it again. If that fails, then that's when you go to the other maneuvers I spoke of earlier on. Thank you.
Excellent. Thank you so much for the video. Makes things clearer to those who are not obstetricians. Thank you. So questions, any questions kindly? Veronica, your hand is still up. Could you kindly unmute yourself and then go ahead? Veronica Bayo. Okay, so whilst we wait for Veronica, I think probably she may have network issues because she doesn't unmute. Anastasia, kindly unmute yourself and go ahead.
All right, good afternoon, Doc.
Good afternoon.
Good afternoon.
At this stage, the woman will be in severe pain. So if you are doing these forms of maneuvers, would there be any anesthesia given so that the woman can relax for you to do the maneuvers?
Okay, thank you very much for your question. So if you look at the whole scenario of shoulder dystocia, it's a dire emergency such that there isn't much time to introduce in more interventions than to relieve the woman of the baby of this serious problem. If we were managing our labor already on some form of analgesia, then that would have covered for these maneuvers that you have to do. So let's say the woman is in a big center and she's on epidural, then it's okay. But then all the extra maneuvers you are going to do are not too invasive, such that they will cause so much pain to the woman that you have to now go and look for anesthesia before you relieve. We have 5 minutes, remember, so that we don't have a baby that will come back out asphyxiated. Most often, the very first 2 maneuvers are able to relieve majority of the impaction. That is the McRoberts maneuver, and then with application of the suprapubic pressure. If we're able to do this, most often we're able to do deliver the baby, and they are not invasive. The ones that you have to introduce your fingers inside is just at the level of the entrance. That is where the baby's head is out, but the shoulders are just at the symphysis pubis. Just like you do when you are doing your V's, that's where your fingers are going to be. So you don't, it's not like you're going into the cavity of the womb that you need extra analgesia. So if she's already on, fair, that is perfect. But if she doesn't have, we don't spend time looking for the analgesia. That would waste a lot of valuable time. Thank you.
Thank you very much, Doctor. Any more? Yeah, Dr. Charles, please go ahead.
Well, good afternoon, and good afternoon to the presenters. It's been a great presentation, and I want to commend Dr. Frida for how on this presentation. At what point in a facility where you have just maybe a community health nurse and a midwife, at what point do they prepare to refer this case? Because I'm not, I think at the end, if all these maneuvers fail, you have to do the abdominal rescue. So at what point do you prepare to refer the case to probably a facility that has either a theater or a medical doctor? Thank you.
Thank you very much, Dr. Luanga, for your question. So ideally, that is why this presentation is very timely, and it's good that we all are aware of the possibility of this problem and the fact that it is so unpredictable. You cannot tell which baby will end up with shoulder dystocia. So it is good that all midwives, anybody at all who conducts delivery, should be very versed in these drills. So I would recommend that as MSA is doing the EMONC training, we may have to look at adding drills that cover things like shoulder dystocia as well, because the time is so short. For you to get a good outcome, you need to be able to relieve this impaction within 5 minutes. It means that if this woman is doing the delivery in a CHIPS compound, or she's doing that in a health center, most often what can be done easily is the first 2 maneuvers, like I said, the McRoberts and the suprapubic pressure. If the midwife is well trained in all these drills, that's when they can do the internal maneuvers, as in the removal, the turning of the baby, and so on and so forth. So if you lose that time, just know that you just don't want to cause much more injury to the mother, but most often the fetal heart will go away. If you waste time more than 10 minutes, you will not pick any FH anymore. So you don't continue doing much more. If you lose the FH and you've not been able to deliver her, you have to refer. And you shouldn't stop trying, because it won't take 5 minutes for the woman to leave your facility to the referral center. So let's learn the maneuvers, let's practice the maneuvers, but when it fails, we just have to move the woman further for the relief of the obstruction. Thank you.
Thank you, Dr. Howard. Any more? Please feel free to unmute yourself and go ahead. Any questions, comments, suggestions? Yeah, Techno Camo 15. Do you have any question? I see you muted yourself. You can go ahead. Yeah, I suspect that would have been an error. Please, if you have any questions, any comments, kindly feel free to unmute yourself and go ahead. We have about 9 minutes. Any questions, comments? Are we all good?
So I hope we succeeded in putting the information across and not make people a lot more confused in the process. So the way the questions are not coming. But I think there's a lady trying to ask a question. Please come up with your question.
Good afternoon, Evelyn. If you could kindly reposition yourself well, I think there's a break in your voice.
We can't hear you clearly. I don't know whether it's from our end.
Yeah, I think
no, it's the same. It's the same here too.
Yeah. So Evelyn, if you could kindly reposition yourself and then make your comment, or even it's just not. Evelyn, if it's an issue with the network, I would suggest that you probably type it out in the chat box and then we can read and then it will be addressed. Yeah. Please go ahead, Evelyn. I think it's better now. Yes, go ahead. Oh,
this is Donay.
Oh.
Hi.
Oh, okay, yeah. Dr. Moiba, go ahead.
Okay, so thank you, Dr. Frida, for a wonderful presentation. Well, Dr. Howard, I wanted to do a follow-up question on what one of our colleagues asked concerning sometimes at what point you have to refer if you are in a peripheral facility to a bigger place where you know that other interventions can be done if the initial intervention fails. I'm also thinking that is it possible, even though shoulder dystocia is a bit unpredictable, is it possible that if you have a high index of suspicion concerning that the mother has maternal risk for it, whether to maybe refer, especially if you don't have the expertise for it, refer such patients so that they are not delivered in a facility where, in a case where there's shoulder dystocia and there is no one to conduct, do the maneuvers, there would it will result in some complications.
Okay, so yes. Thank you very much for your question, Dr. Mwaba. The unpredictability of shoulder dystocia makes it such that it's difficult to say this woman or that woman will have shoulder dystocia, and for that reason, let's refer. But so far as obstetrics is concerned, every level of care has the kind of cases that can be kept there. If we follow this protocol, those that are at risk will be at the right places to deliver. It is not predictable that this woman can have a shoulder dystocia. You may even think that, oh, this woman, the baby is small. But then there's some deflection and something happens and the baby's shoulder is not coming through.
Yeah.
It can just happen.
Yeah.
But then if we are following the obstetric categorization of facilities and the kind of cases that should stay, definitely if you're in a health center, you shouldn't manage a diabetic. Do you get my point? If you're in a health center and the woman goes to do a scan and the scan suggests that estimated fetal weight is around 4 kilograms, you should send her forward to a district hospital to go and deliver. So that if we follow our laid down obstetric, we can do some rough selection over there. But I understood Luanga's question to mean that if the thing is happening, at what time do you send the patient?
At what point? Okay.
And I was saying that you should try your best to learn these procedures and then be able to practice them, because you have only 5 minutes. If you just see it and say, I can't do, I want to refer, automatically this baby will get there dead. So it is in our interest and the interest of our clients that we all learn how to manage shoulder dystocia, at least the non-invasive maneuvers that we have to do to disimpact the shoulder. And as I said, majority of the times, 1 and 2 are enough to do the disimpaction. When you have to go very far, then usually the outcome to the baby is very poor.
All right, thank you, boss.
Great, thank you. Yeah, we have about 4 minutes. Any more questions? Or like Dr. House said, most of us have gotten the concept from the very concise presentation that we are either very sure of what we got or maybe we're confused. We hope it's the format that we are very much happy with what we have, and I said there are no questions. If anyone has any, you could just unmute yourself and go ahead. Okay, so in the absence of any questions, we want to say a big thank you to Dr. Frida, Dr. Howard, and everyone who contributed to making this presentation an excellent and concise one. Like we always say, we try to make it within an hour so that then you get the important concepts. And if we need to revisit any aspects of any part of the presentations, depending on your output, we can always do that. Dr. Howard, I'll let you take the last words, your recommendations and any comments, and then we can close for today. Thank you very much.
So thank you very much, MSA, and thank you to our audience for being part of this presentation. I would like to thank Dr. Cabo for the effort she has put in to give us this very concise but insightful presentation. And like we've said over and over again, shoulder dystocia is a dire emergency. We have very limited time to do something to get the baby out safely. Our midwives, please, let's have working clocks in the labor room. Usually they are all full of cotton cobwebs, no batteries, no working batteries, and so on. Let's get working clock, because you are counting seconds to make your diagnosis. So if you don't have a working clock hanging there, and then you'll miss this diagnosis if you are going to use the third diagnostic criteria to make the diagnosis. So let's get working clocks there. Let's practice the drills, because they are not very difficult to practice. And then let's put in efforts to the best to get the best outcome for our clients. Once again, I would like to thank everybody for today, and we're looking forward to next week for another lovely presentation. Thank you.
Thank you very much, boss, and we are grateful, Dr. Frida, for leading us to today's presentation. I see a couple of comments in the chat box asking for the PowerPoint presentation slides. So I've just put up a link to our YouTube handle. If you subscribe to that channel, all the slides and videos, you realize we are recording this session. All the slides and video recordings of each of the sessions on the MSA are posted there. So whether you want the slides or you want the video version of it, just like the YouTube or subscribe to the YouTube channel, and then you should be able to get those ones. I've actually put it in the chat box. When you click on that link, it will take you straight to the YouTube channel. Same as well for our Facebook page and LinkedIn page for updates on the topics for our weekly presentations. So we are so much grateful for your time today. And those are the ways of getting the slides if you want. The next one is going to be a very important topic, which we are looking at, the pathograph. I'm sure you would definitely want to stick to it. Because in the next 2 weeks, we'll be involved in trainings. We may do that in 3 weeks' time when we would have been done with the EMOC drills in the Upper East and then the Upper West. So we'll advertise it on the various channels that you got this advertisement that you got to join us today. As well, like I always say, you don't even need to probably get an advertisement to join us. The same link that you've used today is the same we have been using, like in Ghanaian parlance, they say, since 1900, since we started this presentation. It never changes, the same one. So in 3 weeks, you can just click on the same and you definitely be hooked onto the Zoom platform at 3 p.m., between 3 p.m. and 4 p.m. So we are so much grateful for your time. We're thankful that you joined us today. God bless all of us and bless our wonderful patients. Bye-bye and take care.